A todos, vamos dar continuidade ao nosso Breastmit 2024, quinto simpósio internacional de tratamento mínimo e imagem da mama. E nessa sessão vai ser uma rodada de cirurgia conservadora versus mastectomia. E vamos ter a participação de doutora Melissa Pilesvik, que é uma professora associada de cirurgia e também cirurgiã do Cancer Center da Universidade de Michigan. A doutora irá nos falar sobre acompanhamento a longo prazo e sobrevida para setorectomia mais radioterapia versus mastectomia bilateral em portadoras de mutação. Logo a seguir, vamos ter a doutora Jana de Boniface, que é professora do Departamento de Epidemiologia e Bioestatística do Instituto Karolinska e também do Departamento de Cirurgia da Mama do Kopio Saint-Gohan Hospital em Estocolmo. Ela vai nos brindar falando sobre cirurgia conservadora, melhores resultados oncológicos a longo prazo do que a mastectomia. Ela vai nos brindar com isso. Por favor, professora Melissa.
Hi, thank you so much for the invitation to participate in this meeting. Today I will be speaking on oncologic outcomes, both looking at local outcomes and survival outcomes among BRCA-associated breast cancer treated with breast conservation or mastectomy. I have no disclosures. So I'm going to break this down into a couple of sections. First, we'll look at differences in local recurrence as well as contralateral breast cancer risk between these two different surgical cohorts. Look at survival outcomes between individuals treated with breast conservation or mastectomy, and then current practice patterns among this high-risk cohort of individuals with a deleterious BRCA mutation. So in general, when thinking about our surgical goals in managing BRCA-associated breast cancer, obviously number one is determining appropriate local therapy that adequately treats our cancer to minimize local recurrence and optimizes survival. And then importantly here, assessing future breast cancer risk, taking into consideration both second ipsilateral breast primaries as well as potential contralateral breast cancer risk, and thinking about how these rates may impact local therapy decision-making. So I want to start and look at rates of local recurrence for individuals with a deleterious BRCA mutation who undergo breast-conserving therapy. So this meta-analysis shown here is comparing individuals with a BRCA mutation versus non-carrier controls with an index ipsilateral breast cancer in terms of patients undergoing breast-conserving therapy. And across the board here for ipsilateral breast recurrence rates, you can see that there was no significant difference, with rates reported at 17% in BRCA carriers compared to 11% in the control population. However, in a subgroup analysis, when this was broken down by median follow-up, for studies that have less than 7 years of median follow-up, there's no significance and fairly similar rates of ipsilateral breast recurrence at about 12% versus 9%. However, in studies with longer median follow-up of greater than 7 years, there's a widening of this difference here, about 24% in the gene carriers compared to 16% in the controls, suggesting that these may not be true local recurrences, but rather second primary breast cancers that are developing over time. In a more recent updated meta-analysis reported very similar results here. In these forest plots on the left, you see studies that are comparing BRCA mutation carriers compared to non-carrier controls with fewer than 7 years follow-up following breast-conserving surgery, with no significant difference in a risk ratio of 1.49. However, with longer median follow-up, at the top we see here greater than 7 years, and on the bottom studies with greater than 10 years of median follow-up, we see a significant difference now with a risk ratio of 1.5 at greater than 7 years and 1.6 at greater than 10 years. So this information is really helpful when we're thinking about the longevity of a patient and their life expectancy and how this long-term second cancer risk may impact local therapy decision-making. And the study shown here is a recent study out of JAMA Network Open that looked at a cohort of individuals with a BRCA deleterious variant and an index ipsilateral breast cancer who underwent breast-conserving therapy. And you see here rates of ipsilateral breast tumor events broken down by those with the BRCA1 variant in yellow and BRCA2 in the blue. There's a non-significant p-value in terms of differences between the two groups, but just looking here over time, at 10 years, you can see somewhat of a difference of the curve, but at 20 years, both of these cohorts have a greater than 20% risk of ipsilateral breast tumor event. Now, when we think about comparing specifically breast-conserving therapy to mastectomy among gene carriers, here we have a review of a number of studies that is broken down in this table based on postoperative follow-up, so at 5, 10, and 15 years. You can see in this table the range, median, and then pooled overall local recurrence rates. So if we focus here on the pooled local recurrence between breast-conserving surgery and mastectomy, at 5 years, there's a small difference here, 8 versus 3%, and that gap continues to increase with increasing postoperative time, 15 versus 5% at 10 years, and 23 versus 6% out to 15 years. So again, suggesting an increasing either late recurrence or second primary breast cancer developing in that cohort of individuals undergoing breast-conserving surgery. And we know that rates of second breast cancer events are very high in women with a BRCA deleterious variant, and this is most frequently reported as the contralateral breast cancer risk among patients who have an ipsilateral or index breast cancer. This is data that was recently reported last year out of the Journal of Clinical Oncology that looked at contralateral breast cancer risk among different moderate and high risk penetrant genes. And here we see the data for BRCA1 on the left and BRCA2 on the right. The gene carriers are represented in the blue line and non-carriers in the red. And here you can see significantly elevated rates of contralateral breast cancer over time following the index breast cancer diagnosis. For the BRCA1 cohort here, up to 20 years, that rate becomes greater than 30%, and in the BRCA2 cohort, over 25%. And so definitely part of our counseling for women who meet these criteria. Again, similarly from the study that I just discussed in women with a BRCA1 deleterious variant and an index breast cancer undergoing breast-conserving therapy, they also reported on risk of contralateral breast cancer and found no significant difference between those individuals with a BRCA1 versus BRCA2 variant, but again, quite high rates out to 20 years at greater than 40%. But importantly, we know that contralateral breast cancer risk is not uniformly the same among all women with a BRCA deleterious variant. And this is a really nice study published in JAMA in 2017 that looked at both breast and ovarian cancer risk as well as contralateral breast cancer risk broken down by BRCA1 versus BRCA2, and also the age at first cancer diagnosis and the time from that index breast cancer diagnosis. And so shown here on the right is a table for individuals with a BRCA1 mutation broken down by the time of diagnosis and the number of years since diagnosis. And there is an identical table in the paper for individuals with a BRCA2 mutation, which is a really nice reference when we're talking to patients. But across the board in this series, they estimated contralateral breast cancer risk at 20 years to be 40%, for BRCA1 and 26% for BRCA2. And importantly, there was a decreasing hazard ratio for contralateral breast cancer events with increasing age at first breast cancer diagnosis. So we do see that the older an individual is at the time of their first breast cancer diagnosis, the lower likelihood of having a second contralateral breast cancer event. And so age at diagnosis, as well as other patient factors, becomes a really important part of this decision making. And now looking at survival, which is ultimately the most important outcome that we assess here, this data is comparing individuals shown here on this slide with a BRCA1 mutation and an index breast cancer who underwent breast conserving therapy versus mastectomy alone in the turquoise line or mastectomy with radiation in the yellow line. Here on the left is breast cancer specific survival and on the right is overall survival. And you can see no significant difference across the board in these Kaplan-Meier curves, but really overlapping survival curves for breast conserving therapy and mastectomy alone. We know that patients who undergo mastectomy with radiation have higher risk features and so often have numerically inferior survival outcomes, but no suggestion here of a worse survival for patients undergoing breast conserving therapy. And similarly, in the same series, when looking at individuals with a BRCA2 mutation, again, we see nearly identical breast cancer specific and overall survival for those individuals treated with breast conservation or mastectomy. And there are a number of reviews now that have looked at reports comparing breast conserving therapy and mastectomy outcomes for individuals with BRCA mutations. Here are two additional series published in 2021 and 2022. Both of these reports found an increased hazard ratio for local regional recurrence following breast conserving therapy compared to mastectomy in a cohort of individuals with a BRCA mutation. However, there was no difference in either review for overall survival here. And similarly, we reported on a cohort of nearly 400 patients with a BRCA deleterious variant and an index breast cancer who were treated in a relatively modern time with multimodal therapy and looked at the same question and compared the group of women who underwent breast conserving surgery versus mastectomy. You can see here that about a quarter of the patients underwent an initial lumpectomy. The remaining patients had mastectomy, with the vast majority opting for bilateral mastectomy. And notably, there was a relatively large population of patients who underwent initial lumpectomy who over time opted for bilateral mastectomies for different reasons. But in comparing these different surgical cohorts of looking at patients with who underwent breast conserving surgery, unilateral mastectomy with a contralateral breast at risk, or bilateral mastectomies, we see no difference in local regional recurrence, breast cancer specific survival, or overall survival. But in the upper right here, we did again see a significant increased risk of contralateral breast cancer among patients who had unilateral breast surgery. And you really see the separation of the curves here after 5 years. And I just wanted to quickly touch when we're talking about mastectomies in this population on the potential role of nipple-sparing mastectomy for individuals with a BRCA deleterious variant. Obviously, there are a lot of factors that go into consideration in selecting appropriate patients for nipple-sparing mastectomy that I am not reviewing here, but this is just one example of a single institution report that looked at just over 100 patients with breast cancer and a known BRCA mutation. These were therapeutic mastectomies, and across the board here you can see excellent survival outcomes. In this cohort, 0 patients had a recurrence at the nipple areolar complex. Notably, they do report that there were a few patients who had a positive nipple margin, and all of those patients had excision of the nipple areolar complex, so all of these patients had negative margins in the series. But across the board, very low rates of local regional recurrence, suggesting in one snapshot that using the criteria that you typically do, these patients may be appropriate for consideration of nipple-sparing mastectomy if there aren't additional contraindications based on tumor and patient features. So what are patients choosing? I wanted to highlight a couple studies here that look at the impact of the timing of genetic testing on surgical decision-making. In this first example, you see the surgery on the bottom, lumpectomy, unilateral mastectomy, or bilateral mastectomy. And this is broken down into individuals who identified a deleterious variant prior to surgery in blue. When that was the case, over 80% of patients in this series opted for bilateral mastectomy. When the mutation was identified after surgery, the vast majority of patients underwent initial lumpectomy. So this information is clearly impacting initial surgical decision-making. And in a second, more recent series, we see a similar pattern. On the left here is a cohort of patients with a BRCA mutation who knew this information prior to surgery compared to patients who found this out after surgery. And we see a significant difference with more patients opting for bilateral mastectomy when this information is known, compared to a much larger proportion of patients opting for lumpectomy when this information is realized later. So an important thing for us to remember and try to optimize the timing of genetic testing results for patients, because we do see that these results impact surgical decision-making. And I just put this here as a reference. This is a nice ASCO summary of local therapy considerations for women with breast cancer and a BRCA deleterious variant, highlighting that the genetic status should not preclude breast conserving therapy, but that patients should be counseled on the potential increased risk of second primary breast cancer and contralateral breast cancer risk, and a consideration for mastectomy should be discussed and taken into consideration patient age, overall prognosis from breast cancer or potentially ovarian cancer, as well as patient comorbidities and life expectancy. Importantly, they highlight here that for individuals with a BRCA mutation who do not undergo bilateral mastectomy, ongoing high-risk surveillance with mammogram and MRI annually is vital given those increased rates of additional cancer events. So in conclusion, breast conserving therapy and mastectomy are associated with similar survival outcomes among individuals with BRCA-associated breast cancer. And while early local recurrence events may be similar, there appears to be an increase in late second cancer development and rates of contralateral breast cancer development over time. Among women with a BRCA variant who do opt for breast conserving therapy, ongoing surveillance with mammogram and MRI is important, and all of these factors should be discussed with patients when counseling women on their surgical decision making. Thank you for your time, and hopefully I will be able to address questions. Thanks.
Good morning or good day or good evening, wherever you are, and thank you for the kind invitation to contribute to this wonderful seminar. So my topic is to talk about breast conservation and long-term oncological outcomes compared with mastectomy. So on my agenda is partly to talk about the survival outcomes after primary surgery and also touch upon high-risk subgroups. We'll then also talk about oncological outcomes after neoadjuvant treatment, but I will not talk about patient-reported outcomes and health economy. Now, we do have randomized evidence comparing breast conservation and mastectomy. This is an example of the NSABP B06 trial with its 5-year follow-up. And I wish to show you here that when the 5-year follow-up was published, you could actually see a significant advantage for patients who had undergone segmental mastectomy or breast conservation, including radiotherapy. And that was also slightly visible in overall survival, even though that was not statistically significant. When 20-year follow-up was published, however, you see that the curves overlap, so there was no significant difference in any of the outcomes here. And you might, in theory, just give a thought to why that might be, because in those times, these patients were enrolled in the 70s and 80s. And as we know from a fantastic publication here in the Lancet Oncology from 2005, the radiotherapy for breast cancer patients in the 70s and 80s increased the risk of lung cancer death about threefold if you follow up for 15 years or more. The same is true if you look at cardiac mortality. The risk of a patient who had radiotherapy for breast cancer in the 70s and 80s and was followed up for 15 or more years had nearly 3 times higher risk to die. So who knows, you could hypothesize that the randomized trials on breast conservation versus mastectomy were hiding a positive effect for breast conservation simply because of the toxicity of the radiotherapy. So if we today look at non-randomized real-world evidence from cohorts and registers, what most summary publications, and this is one of 3 I will going to show you, what all of these show is a favor over survival favoring breast conservation. So this is a Danish publication. This is from the same year, 2022. Even more studies here included, and you see the overall effect definitely favors breast conservation in terms of overall survival. And lastly, also here, was published this year, Rajan et al. In Shelley Potter's group. You can also see here all these studies showing in the end an overall effect favoring breast conservation in terms of overall survival. And what I want to point out in this figure is also another thing, is that you see the vertical line here in the middle, which is the watershed between breast conservation and mastectomy. And all the trials that lie on the left of this would favor breast conservation. If the entire line, meaning the entire confidence interval, is on the left of that vertical line, then it's significantly better to receive breast conservation in terms of overall survival. And what I want to point out here is that there's not one study showing a significant association between mastectomy and better survival. Now, if we look at non-randomized data, what we need to take into account is that the process of finding the decision of what type of surgery to perform is very complex and will never be mirrored in any type of non-randomized setting. So all the preferences, priorities, fears and anxieties of both patient and physician will never be represented if you don't randomize. But as we won't have any more randomized trial on the topic ever again, I believe, I think that's as good as it will get. What we also have is a lot of confounders. A confounder, of course, needs to affect both the exposure, in our situation, the type of breast surgery, and the outcome, in our case, survival. And all these blue bubbles here are actually true confounders because they affect both of them. Now, some of these confounders will be possible to adjust for in multivariable analyses, but others will not. So if you look at a curve like this, which was published by us in 2021, this is unadjusted Kaplan-Meier curves. You should actually not really trust them because the differences, the baseline differences between these groups might be so different that once you adjust for the background data, these lines would possibly not separate at all. Why? Because if you look, for example, at patients receiving mastectomy without radiotherapy, they're quite different to the typical patient who received breast conservation with radiotherapy. These patients have, of course, larger tumors. That's a technical problem. They are more often lobular histology and higher grade, but they are often older, high median age. They have more often a low income, short education, and at least one comorbidity. So the patients traditionally who receive mastectomy without radiotherapy are the frailer ones, the ones that maybe actually don't benefit from more extensive surgery. So in all these cohort studies, everybody has made attempts at adjusting. Depending on how many confounders were available, you have to adjust for all of those that you can actually find. In our case, we had a stepwise model, but if we look only at the final model here to your right, you see for overall survival, the association with worse survival is at a hazard ratio of 1.79, benefiting breast conservation, and in breast cancer specific survival is 1.66. So this is after adjusting for socioeconomic, clinical characteristics, and so forth. Now, of course, even in this study and in all the other studies, there will always be residual confounding, which we'll never get rid of. And that is the big disadvantage of non-randomized trials, which is why I sometimes don't tell my patient that they will benefit in terms of survival from breast conservation, but they will at least not have a worse choice than mastectomy. So is that all due to radiotherapy? Is the survival benefit seen with breast conservation due to radiotherapy? Well, I need to point out there that in our study, we actually included mastectomy patients who received radiotherapy. And after all the adjustments, you see still a significant association with a worse overall survival and a worse breast cancer specific survival. You see that the effect is slightly smaller than when you look at the mastectomy without radiotherapy group, but it is still significant. And that was also shown in the meta-analysis from the UK that I just showed you. These are all the studies that actually looked at mastectomy plus radiotherapy and compared with breast conservation. And you see here that all of the trials, apart from one, lie to the left of that magic vertical line, and you see that the overall effect is about 0.7 something in favor of breast conservation. So what about high-risk groups? Triple-negative breast cancer is certainly a high-risk breast cancer, but does it really matter how we operate them? Well, it seems the answer is no. Because if you see here, all the trials and studies that looked specifically at triple-negative breast cancer have favor breast conservation, because here again, all the effects, effect measurements lie on the left of the vertical line. The same is true for young age. There's only one single study that shows the opposite and favors mastectomy. All the others are on the left side of the vertical line and have thus an overall association with better survival if you conserve the breast. Older age is possibly not seen as a high-risk population, but I still would like to discuss it here. First of all, regardless of age, we know that major surgical complications are more common after mastectomy than after breast conserving surgery. It's about 4.7% versus 2% in our studies, but I've also seen larger differences than that. We have also seen that major surgical complications actually in our population are not more common in older age groups. What is more common is major medical complications such as myocardial infarction or infections. These increase with age. So if you look at women 80 years and above, the rate of major medical complications is 2.3 after breast conservation and 6.2% after mastectomy. And if you look at the association of medical complications and survival, and the medical complications are significantly associated with higher mortality in older individuals who receive mastectomy. So I think we should take special care of our older and possibly frailer patients, because they should not have unnecessarily extensive surgery. Now, the national trends of breast conservation in Sweden, you see here a slow increase over the last decade. This is in tumors up to 3 centimeters. But what is more interesting is actually if you look at invasive tumors of any size, because you see the increase, especially for the last years, is much steeper than if you look at the smaller tumors, which tells us that the real increase in breast conservation lies in the patient group with larger tumors. So does breast conservation work in larger tumors? Well, technically, yes, it does. We do have the oncoplastic techniques to remove larger tumors from the breast with a cosmetically satisfying result. We also know that even though we do more complex oncoplastic procedures, they have still fewer complications than a simple mastectomy. This is data from Shelley Potter from 2020, and you see here that any major complication after a therapeutic mastectomy is only 2.1%. While if you look at the same figure for mastectomy only, it's actually 5%. And a bit worrying is actually, if you look at mastectomy, immediate breast reconstruction is a staggering 14%. And similarly, the Part BRECON study, which was published last year, shows also a major complication in 2.6% of patients. This is patients who received a perforator flap for breast conservation. So very low complication rates. Does it work oncologically? Yes. This is a huge study of 19,000 patients with T3 tumors, 16,000 of whom had a mastectomy and nearly 3,000 breast conservation. And you see, when adjusted for clinical factors, that overall survival did not differ whatsoever between the two groups. There's also no increased risk of local recurrence. Now, this is from our own publication from 2021, where we compared standard breast conservation with simple and complex oncoplastic procedures. Why do I show this here? Because the complex OPS, oncoplastic surgery group, the green line, includes the highest proportion of large tumors. And you see that over time, there's absolutely no difference in the occurrence of local recurrences. And this was also shown in a Cochrane overview, where it was compared oncoplastic breast conservation versus standard breast conservation. Again, I'm showing this because oncoplastic breast conservation naturally includes a higher proportion of patients with larger tumors. And you see here, for local recurrence, for example, a hazard ratio that is crossing the midline, so 0.90, and no significant difference between the two groups. Of course, the certainty of evidence was graded as low or very low, but we at least don't have any evidence for an increased risk of local recurrences. Does it work after neoadjuvant treatment? Well, we know from the EBC-TCG analysis the worrying increase of local recurrences in patients who were treated with neoadjuvant therapy. But I want to remind you that these patients were treated in old trials, and we're not really sure what was actually removed. Even if in these trials surgery was commonly used, as it said, it's unclear what margins were achieved and how multifocality and imaging was actually handled. If we look at more modern data, this is also breast conservation versus mastectomy in the randomized I-SPY trial. The two blue lines represent patients with pathologically complete response. Breast conservation and mastectomy don't differ whatsoever. Again, here the two red lines, that's patient with residual cancer burden, and also here breast conservation versus mastectomy, there's absolutely no difference. So what we should look at for the risk of local recurrence after neoadjuvant therapy is not the type of surgery we use, but rather the subtype and whether or not there's residual cancer burden visible on histopathology. And that was also shown in a Dutch study here. One important point was if you look at mastectomy patients after neoadjuvant treatment, then the tumor and nodal stage is significantly higher, which is easily seen if you look here, breast conservation, distant recurrence in 9%, while in mastectomy patients it was nearly 20%. So the mastectomy patients have clearly worse disease. So if you would now not adjust for clinical factors and only use the crude hazard ratio, you would have double the risk for recurrent disease if you have a mastectomy. But actually, if you then adjust for these clinical factors, the node status, the subtype, the PCR, then there's no difference between mastectomy and breast conservation. What we really need is standardization of local regional treatment reporting. So we need always to have information about margins and the type of surgery used. And we hope to get that done in the Precedent project led by Shelley Potter and Stuart McIntosh. So in summary, I think I could show to you that there's absolutely no data showing that mastectomy would convey a survival benefit, and BCS is consistently associated with a survival benefit in primary surgery. And that is also valid for high-risk subgroups. There's more complications after mastectomy, those matter for survival, and possibly especially important for older patients. There's no increased risk of local recurrence after breast conservation, and after neoadjuvant treatment, there's no increased risk of recurrence or death for breast conservation patients. I didn't touch upon pros, but I do need to say that patient-reported outcomes never favor mastectomy, and health economy considerations do not favor mastectomy either. So I think in summary, we can say breast conservation wins. Thank you for your attention.
Obrigado, doutora Jana, obrigado, doutora Melissa. E agora nós vamos iniciar os debates. Temos 4 debatedores, eu queria que vocês fossem bem objetivos. Teremos no debate o Dr. Régis Paulinelli, que é presidente do Departamento de Oncoplastia da Sociedade Brasileira de Mastologia, médico titular do Hospital do Câncer Araújo Jorge e do Hospital Alberto Einstein, em Goiânia. o professor Ruffo de Freitas Júnior, mestre e doutor pela Unicamp, professor associado da Faculdade Federal de Medicina de Goiânia, médico titular do Hospital do Câncer Araújo Jorge. Dr. Leandro, oncologista clínico, diretor clínico do grupo Oncomed. E, por último, não menos importante, Dr. João Paulo Faria, médico geneticista, mestre e doutor pela Universidade Federal de Minas Gerais, membro do corpo clínico da Oncoclínica no Hospital Felício Roxo. Régis, vamos lá, nossas considerações. Temos aí um tempo de 15 minutos para a gente discutir um pouquinho, tá? 20 minutos nós temos. Por favor, Régis.
Ótimo, um prazer estar aqui com vocês. Parabéns pelo tema, muito bem selecionado. A gente vê, apesar de todos esses benefícios do tratamento conservador, a gente ainda vê muitos pacientes preferindo a mastectomia e muitos médicos também não acreditando que o tratamento conservador seja equivalente à mastectomia, pelo menos, se não melhor. Então, a gente ainda tem um longo caminho a desmistificar sobre esse assunto. Eu tenho um comentário para a doutora Jana de Boniface e tenho uma pergunta para a doutora Melissa. Para a doutora Jana de Boniface, eu queria comentar que a gente concordo perfeitamente, totalmente com os pontos que ela colocou. Eu acho que vale a pena a gente tentar o tratamento conservador mesmo em tumores localmente avançados. E a gente publicou, o ano passado, uma comparação entre as pacientes que fizeram tratamento conservador com oncoplastia e as pacientes que fizeram mastectomia com reconstrução de mama. Em geral, as pacientes que fizeram tratamento conservador estavam mais satisfeitas, tinham menos complicações, não tiveram prejuízo oncológico, e as pacientes que faziam mastectomia necessitavam de mais cirurgias para completar a reconstrução. Então, tinha vários benefícios. E agora nós estamos prontos, já terminamos a análise, já estamos na fase final para publicar um artigo que vai ser a maior série de conservação em tumores localmente avançados e multicêntricos, que seria a oncoplastia extrema. Então, é uma série grande de quase 300 pacientes, comparado com a oncoplastia convencional, com a mastectomia em tumores grandes, com a mastectomia em tumores pequenos. E o que a gente observou foi bem interessante. A oncoplastia, nesses tumores localmente avançados, teve a mesma taxa de recorrência local, as mesmas parâmetros oncológicos do que as pacientes com tumores iniciais. E, novamente, a gente encontrou da mesma forma que as pacientes que faziam mastectomia, seja para tumores localmente avançados, ou seja para tumores iniciais, estavam muito menos satisfeitas com as cirurgias, precisavam de mais cirurgias, tinham mais complicações, tinham pior simetria, elas pontuavam pior em quase todos os quesitos lá do BreastQ. Então, a gente, novamente, a gente reforçando o que a doutora Jane comentou, que vale a pena a gente colocar isso para a paciente e, quando possível, mesmo se necessário associar alguma técnica de oncoplastia, vale a pena tentar o tratamento conservador nesses casos. E para a doutora Melissa, eu queria eu queria perguntar uma coisa. A gente sabe que é perfeitamente possível fazer tratamento conservador nessas pacientes BRCA1 e BRCA2 que não querem fazer uma mastectomia. A gente vê que não vai ter prejuízo de sobrevida, apesar de ter um aumento da recaída local. Eu acho que o maior problema sejam aquelas pacientes que não têm mutação genética, que o painel é negativo, que tem uma história familiar pobre e que não tem uma mutação, não tem mutação ou tem uma mutação de baixa penetrância e chegam para o médico, para o cirurgião, pedindo para fazer uma mastectomia bilateral. Eu queria saber como que a doutora Melissa costuma abordar essas pacientes, que tipo de informação costuma passar para elas e como que geralmente é conduzido essa situação, que é relativamente frequente nos consultórios.
O Régis, me parece que a doutora Melissa não está online.
Ah, sim.
Mas seria interessante que, se a doutora Jana pudesse responder a sua pergunta.
Acho que sim. Doutora Jana, por favor, se possível responder.
Sure, I can try to step in for Melissa. Can you hear me okay?
Yes. Sim.
Okay, I think the problem is a little bit less on this side of the Atlantic Ocean. We do have some patients who request bilateral mastectomies, as you said, without any increased genetic risk, but it's not as common. And I think we have such good arguments for breast conservation in those patients because we don't see this increase of local recurrence as we would see in the genetic risk patients. So we usually do our best to convince the patients that, especially if you look at the long run, as you just said yourself, their life will be much less affected negatively if we do the least possible operations for breast conservation instead of doing a bilateral mastectomy, because it usually, as we just said, the consequences are often more revisional surgery, and in the long run, and especially in younger patients, it's a hassle, to be honest. So I think we have very convincing arguments, because now I just talked about the survival bit, right? It was not my topic to talk about quality of life or healthcare costs or any type of kind of the other benefits which breast conservation brings. And I think if you put all that together, there's really hardly any arguments left for mastectomy if we talk about the non-genetic risk carriers.
Obrigado.
Dr. Ruffo, por favor.
Bom, olá, pessoal. Primeiro, falar uma coisa muito importante. É uma honra estar aqui com a doutora Jana de Boniface. A doutora Jana de Boniface fez um favor enorme para toda a comunidade científica e para milhões de mulheres no mundo inteiro a respeito das duas publicações esse ano sobre o Senomac Trial e da possibilidade de mostrando a não necessidade de esvaziamento axilar em pacientes submetidas, né, ali com 1 a 3 linfonodos comprometidos, e ela mostrou com muita elegância que mesmo na era de inibidores de ciclina, a não necessidade de esvaziamento. Doutora Jana, a senhora tem assim um lugar no céu e o agradecimento de milhões de mulheres no mundo que deixarão de ter as axilas esvaziadas sem necessidade. Bom, agora indo para o tema, doutor Tufi, a grande questão foi a mudança, e a doutora Jana colocou muito bem na apresentação dela, foi brilhante, e mostrando que a conservação da mama é tão boa e, eventualmente, melhor que a mastectomia. Desde o desenvolvimento das terapias adjuvantes, principalmente a melhoria da radioterapia, e o desenvolvimento das terapias sistêmicas, incluindo o controle, o melhor controle local por quimioterapia, endocrinoterapia, e agora também, por que não dizer, com os inibidores de ciclina, todas essas terapias acabaram melhorando o controle local. Dessa forma, já os grandes estudos haviam, naquela época dos grandes estudos, ainda nós não tínhamos o que nós temos de terapia sistêmica, e ainda assim, todos os grandes estudos mostraram uma equivalência entre o tratamento de mastectomia versus a conservação da mama, e mostraram que era exatamente, depois de 25 anos, que era exatamente igual. No topo dessa história, nós aprendemos que a quimioterapia reduz também o risco de recidiva local e, dessa forma, muitas vezes nos permite, com as técnicas adequadas hoje de terapia sistêmica, conforme eu falei, um benefício maior ainda, permitindo, junto com a oncoplastia e aquilo que o Dr. Régis e que nós publicamos a respeito de, mesmo em mamas grandes com tumores também não pequenos, né, T3, a possibilidade de boas conservações mamárias, principalmente nas pacientes que apresentam tumores luminais. Essas, com a possibilidade, muitas vezes, que elas não terão de fazer quimioterapia adjuvante. E mais do que isso, com a possibilidade que nós temos de, eventualmente, também não ter que esvaziar as axilas depois, fazer uma cirurgia de fronte, uma conservação da mama será muito mais bem indicada. Doutora Jana, parabéns pela sua apresentação. Nós somos fãs incontestáveis da cirurgia conservadora, e a senhora, com a sua apresentação, nos permitiu um brilhantismo, a possibilidade de termos um flavor de como funciona. Obrigado, presidente.
Eu gostaria de
Really
convidar...
kind words. I just need to say, I've never heard anybody to say, I've got a special place in heaven. I'll write that in my diary today. Thank you.
Dr. Leandro Ramos, oncologista clínico. Algumas considerações, Leandro, por favor.
Sim, Tufi, obrigado aqui, né, fico muito feliz de estar participando aqui com vocês desse grupo bem seleto de médicos, né, que estão diretamente relacionados e lidam muito com câncer de mama. Bom, o que chama atenção ao longo de toda essa jornada é a importância do descolonamento, né? A gente tem visto que diminuir questões cirúrgicas, tanto da mama quanto da axila, isso nos permite manter a eficácia mantendo a sobrevida, a eficácia do tratamento, sem ter as perdas, né, que uma cirurgia radical da mama ou na axila traria para a paciente. Então, é importante também nós, médicos, oncologistas, mastologistas, lembrarmos da importância de termos o dado do BRCA, né, conforme a doutora Melissa mostrou, e também a gente sabe que esse dado nos aumenta a sobrevida, uma vez que eu consigo usar um inibidor de PARP na adjuvância. Então, hoje, a gente tem muito em mente, assim, tem que pedir imunistoquímica, ninguém trata câncer de mama sem imunistoquímica hoje. E também a gente tem que lembrar que tem que pedir o estudo genético, né? Muitas vezes a gente está com aquela mania de pedir estudo genético, alguns oncologistas pensam assim, só no triplo negativo. E a gente viu que não é verdade. Tem o BRCA2, que tem também uma possibilidade de ter um receptor hormonal positivo e essa paciente ser mutada. E essa informação muda completamente o tratamento dessa paciente, aumentando a sobrevida quando eu acrescento o olaparib. Né? Então, esse ponto, como oncologista clínico, eu gostaria de frisar. E outro ponto, mesmo que a gente comentou, a doutora Jana foi brilhantemente enaltecida aqui pelo Dr. Ruffo, e com toda a razão, mas tem algumas situações também que a cirurgia conservadora, gostaria de frisar isso também, elas, infelizmente, a gente tem um pior, por exemplo, no câncer inflamatório da mama, né, que a gente faz quimioterapia neoadjuvante, mesmo assim tendo uma resposta completa, clínica, ainda é um ponto que a mastectomia ainda é melhor, né, no meu entendimento, do que uma cirurgia conservadora. Eu só queria colocar esses pontos, esses contrapontos, e, mais uma vez, parabenizar aí a doutora Jana, a doutora Melissa e a todos os componentes da mesa e agradecer aqui estar com vocês.
Obrigado, Leandro. E agora eu gostaria de convidar o doutor João Paulo Faria, se vai fazer algum comentário como geneticista. Por favor, João.
Agradecer o convite de vocês. É uma honra estar aqui com os pares, igual o Leandro disse. Parabenizar a doutora Jana e a doutora Melissa pela brilhante explanação. Queria acompanhar as pontuações do Régis e do Leandro a respeito do descalonamento, né? As pacientes com as variantes de BRCA, que são propostas a mastectomia, é um temor nas pacientes, né, de como que vai ser o resultado, o que vai acontecer pós-cirúrgico. Então, os trabalhos que mostram que a cirurgia conservadora mostra benefício, apesar do aumento do risco da contralateral, isso endossa a condução no consultório. Eu queria só salientar e deixar para a posterioridade aqui, né, que na linha do que o Leandro falou, né, de testar, mas irmos sempre além dos BRCAs, né? O Régis até falou dos genes de baixa penetrância, mas na nossa amostragem de Belo Horizonte, BRCAs são responsáveis por 35% dos resultados. Tem vários outros genes aí de média e de alta penetrância e genes que a gente não sabe ainda a penetrância deles. E também salientar os padrões negativos. Eu estou construindo um banco de dados agora e eu acho que esse é o maior desafio nosso, as famílias que têm expressões de genes monogênicos, mas do sequenciamento não pega nada. Isso é um desafio também, que tem família que você vê lá que é cara de BRCA, tem até câncer de mama masculino e o teste é negativo. Isso é um desafio para frente, mas acho que o modelo do BRCA é um bom ponto de partida para todos.
Muito obrigado, João. Doutora Jana, deixa eu fazer uma pergunta à senhora. Uma paciente com mutação, jovem, 30 anos, e isso foi discutido no nosso Congresso de Oncologia, e ela pretende ter filhos, tá? E ela teve um câncer, fez uma cirurgia conservadora, está bem, mas ela é mutada. Qual seria a recomendação da senhora para que a gente preparasse essa jovem para ter filho? A senhora contraindicaria ou não? Ou tomaria alguma outra medida?
Now, are you intending in terms of risk using surgery or in terms of adjuvant treatment?
Yes.
Both,
Sim.
okay. Yeah, well, I would think like for the local regional treatment, if she is opted for breast conservation, which is maybe in our country relatively rare, I would certainly let her go along with that. If she wants to have children, I mean, certainly if she, depending on what type of tumor she had, I would recommend her following her adjuvant treatment recommendations. So I don't know what your patient had, but if she was a triple negative patient, for example, she might have had neoadjuvant chemotherapy, right? So I would certainly think that is really important to receive the appropriate systemic treatment for her at that point in time. In terms of surgery, I suppose you're thinking about breastfeeding later on if she's intending to have children. I would have a very open discussion with her because we've just seen these figures of the risk of contralateral breast cancer and ipsilateral recurrence or new cancer over time. And we've also seen that the risk is not exactly, it's not so high in the first years. So I think there would be an option to have this discussion with her to just have us under surveillance, because also the adjuvant treatment will have an effect on both breasts and the risk of recurrence for quite some years. But I suppose, at least in our country, we would then look at, once she's had her child or children, that we would then go for usually bilateral mastectomy if we're talking about BRCA carriers, BRCA carriers. Of course, the lower penetrance genes, that is a completely different discussion again.
Ok, eu queria agradecer à doutora Jana pela sua participação, agradecer a todos os debatedores e vamos dar por encerrada essa sessão. Um bom fim de semana a todos vocês.